preventing and treatment of the periodontal disease. Periodontics means it is a study deals with the prevention and treatment of the periodontal disease. Today we will have a short introduction about the periodontics, then we will go ahead with the discussion about the questions. Okay. So now you should know what is periodontium. It is actually a Greek word. Peri means outer, Odontium means surrounding the teeth. Odontium means tooth, and what we are going to do is the tooth surrounding structures. Peri means around, Odontium means tooth. So we are going to deal and we are going to study structures surrounding. Okay. See, when you take as the periodontium, there are 4 things involved in the periodontium. One is gingiva, second is periodontal ligament, cementum and alveolar one. All 4 joints together only we call it as a periodontium. Now you should know attachment apparatus. We are saying now periodontitis means it involving attachment apparatus. Actually what and all comes as attachment apparatus is all 4, but in this 3 is going to be the supporting structures and gingiva is going to be the investing tissue. Okay, we always used to say periodontitis means it's a disease affecting the supporting structures of the teeth. Illaya? Ipo ungalku ginger investing tissue of the teeth, they will put all 4. That time you should feel gingiva is the investing tissue and all 3 is going to be the supporting structures of the tooth. Okay. See, in periodontium there is gingiva, cementum, periodontal ligament, alveolar bone, isn't it? Cementum, periodontal ligament, alveolar bone and gingiva. All these things will join together, will form a periodontium. So the periodontium consists of investing and supporting tissues. In this, I told you gingiva is the investing one, periodontal ligament, alveolar bone, cementum. All 3 is going to be the supporting structures. I will tell you why the gingiva we are calling it as an investing tissue later when I am taking a class on trauma from occlusion. Okay. See, now let us go directly to the gingiva. So this is a macroscopic structure of the gingiva, that is marginal gingiva, attached gingiva and interdental gingiva. You know about the marginal gingiva. Marginal gingiva is, what do you mean by gingiva? It is a part of the oral mucosa that covers the alveolar process of the jaw and surrounds the neck of the teeth. Okay, ma? So if they are asking gingiva means it is a oral mucosa that covers the alveolar process of the jaw and around the, usually the student will say the mucosa surrounds the neck of the tooth. Not that. It is a covering the alveolar process of the jaw also. See, there is a free gingiva from where to where? It is from the margin to that of this, and marginal gingiva to attached gingiva there is going to be a free gingival groove. This free gingival groove it will demarcate this gingiva from that of the attached gingiva. Okay, ma? So this marginal gingiva, it will extend till the external protuberance of the gingival sulcus. Okay, if the gingiva starts from CE junction to that external protuberance, otherwise base of the gingival sulcus, you are going to see the free gingival groove. From that to loose alveolar mucosa, you will be having an attached gingiva. Okay, ma? From external protuberance of the gingival sulcus to that of the loose movable mucosa, you will have an attached gingiva. So from this to that of the mucous thing, we will call it as a mucogingival junction. From attached gingiva to alveolar mucosa, there is a mucogingival junction. Now you understood what is free gingiva, what is attached gingiva, what is mucogingival junction. Is it okay? Right. This is a microscopic structure of the gingiva. Before that, I want to tell you what is free gingiva. Attached gingiva is keratinized gingiva. Attached gingiva is a keratinized gingiva. We call it, it is firm and resilient. Why it is keratinized? So that it can withstand the frictional forces on mastigation. Okay, ma? So attached gingiva is a keratinized gingiva. It is firm and resilient so that it can withstand the frictional forces on mastigation. That even used to ask you in the MCQ. Now, see this microscopic structure of the gingiva. So we always call this gingiva, the principal cell of the gingiva is keratinocytes, isn't it? Principal cell, there are 2 things you should remember. The principal cell of the gingiva is keratinocytes, principal cell of the periodontal ligament is fibroblast. Okay. So usually they used to ask in MCQs. Whatever they are asking in MCQs only, I am giving it now. Okay. See, the microscopic structure of the gingiva has three types of epithelium: oral epithelium, sulcular epithelium, junctional epithelium. In that you should know the differences between these three. The oral epithelium usually covers the outer surface of the gingiva. Am I right? Isn't it? And sulcular epithelium, junctional epithelium, both are non-keratinized epithelium. Okay. So naturally this oral epithelium is going to be keratinized because it covers the outer surface of the gingiva. So the sulcular epithelium and junctional epithelium are non-keratinized epithelium. Now we should know what is how the junctional epithelium only, because we are giving more important for the epithelium because the turnover rate of epithelium is higher than any other tissue. The turnover rate of epithelium is more, isn't it? So why we are giving importance to junctional epithelium? Because most of the time it acts as a barrier for permeability. Okay. So the difference between the oral epithelium and junctional epithelium is, number one, the cells will be wider. Ella cellum thanitaniya wider, and you will have a more gap between each cell. Okay, this is the main difference you should understand. In this junctional epithelium, the cells will be wider. That means bigger in shape compared to other things, and there will be a cell gap will be more. Why? Because I already told you it will act like a permeability barrier. You have understood? Oral epithelium, sulcular and junctional. These are the possible questions they can ask in this. See here, this epithelium is stratified squamous epithelium, basement membrane, lamina propria. Here what you should understand here is the basement membrane forms a continuous layer. There won't be any gap. The basement membrane forms a continuous layer. In this epithelium what happens? It dips as a epithelial retipex into the connective tissue. The epithelial retipex will enter the connective tissue and continuously they will form a epithelial bridges. Okay, the epithelial bridges enga irukonu keta, gingivala there is an epithelium connective tissue, both are separated by means of the continuous layer of the basement membrane. The epithelium will project into the connective tissue as a retipex. When it is coming like a retipex, the upper part will become a continuous epithelial bridges. Okay, so don't think, in case they are questioning epithelial bridges, what it is. That is nothing but a epithelial retipex which forms continuous in the connective tissue. Okay. Now, what are the things present here? Cells, fibroblasts, mast cells, macrophages, inflammatory cells. These are the cells present in the gingiva. And fibers, collagen fibers, reticulin fiber, osteodylan and principal fibers and secondary fibers. These are all the cells and fibers present. Now blood supply. Usually in MCQ they used to ask the questions in this blood supply. So the blood supply of the gingiva is alveolar artery. Okay. In that nerve supply means maxillary and mandibular. So you remember the blood supply of the gingiva is alveolar artery. In nerve supply in maxillary, nasopalatine nerve, it supplies facial aspect of the anterior teeth. Nasopalatine, facial aspect of the anterior teeth. And posterior superior alveolar supplies the facial part of the posterior. புரியுறதா? இது வந்து first வந்து nasopalatine anterior, posterior superior alveolar on the posterior. This is only on the, I am telling about the facial aspect. Now we should go for the lingual aspect. Here, greater palatine artery supplies lingual aspect of the posterior teeth. Is it okay? And anterior palatine nerve supplies the lingual aspect of the anterior teeth. So remember, in maxillary, there is a nasopalatine nerve supplies facial aspect of the anterior, and posterior superior alveolar nerve supplies the facial aspect of the posterior, and anterior and posterior lingual part by means of the greater palatine, and anterior by means of the lingual aspect of the anterior thing, anterior palatine nerve. You have understood now? So you remember anterior nasopalatine nerve, posterior superior alveolar nerve, greater palatine nerve, anterior palatine nerve. You remember now? All these for maxillary. In mandibular, inferior alveolar nerve. Okay, inferior alveolar nerve for a mandibular. Is it okay? Blood supply and other things. Shall we go to the next slide now? Now, we will come to the periodontal ligament. The periodontal ligament is composed of complex vascular and highly cellular connective tissue. Vascular and cellular connective tissue that surrounds the tooth root and attaches it to the alveolar bone. So, this periodontal ligament is the bridge between the tooth and that of the bone. Okay, ma? Tooth root is surrounded by means of the cementum, and here this is going to be the alveolar bone. Between that is going to be the periodontal ligament. The periodontal ligament plays a major role in supporting the tooth. Okay, the average width of the periodontal ligament is 0.2 millimeter. See, if you are not understanding, please stop me there. Now, so you should know what is the histological structure. The periodontal ligament composed of cells and intracellular substances. When its cells come, synthetic, resorptive, progenitor, defensive. These are the 4 types of cells present in the periodontal ligament. And intracellular substances, fibers, ground substances, blood vessels, nerves and lymphatics. Okay. So, these are the fibers. Most important are the principal fibers. In that, other fibers, oxytocin, elonine fibers are immature elastic fiber. There are 2 types of fibers will be there, mature and immature. Okay. The oxytocin fibers is used to be a immature elastic fiber. What is the use of elastic fibers? You should know. When the force is applied to the tooth, the periodontal ligament fibers gets recoiled and then it will come back. That is the action it will take place. I will tell you the theory about it. This will act like observing the forces, shock absorption. Okay, occlusal forces it will get clear. And collagenous, arranged in bundles, a wavy course when viewed in a long. So, all the principal fibers are collagenous fibers and they will be arranged in bundles. Okay. Apart from this fibers, they will be having an immature elastic fiber that is only called as oxytocin and elonine fibers. And now you should know Sharpie's fibers. This is very important, usually they are asking in the orals. Terminal portions of the principal fibers that embedded, that inserts in the cementum and bone. So, I told you already root cementum and the bone. Nadula ellame principal fibers. The terminal portions which ends on both the sides is going to be the Sharpie's fibers. Okay, va? The principal fibers are gingival fibers, transeptal ligament fibers and periodontal ligament fibers. These transeptal, what is the importance in transeptal fibers? It is for both. Even in gingiva there is a transeptal fibers. Isn't it? That's the main thing. In periodontal ligament fibers, the oblique fibers will be abundant in nature. These 2 questions usually they will ask. One is oblique fiber which is abundant in nature and transeptal fibers is for both gingiva and periodontal ligaments. This is what I told you, the importance of Sharpie's fibers and periodontal. 2 theories very, very important. One is tensional theory, other one is viscoelastic theory. That's what I was telling about shock absorption. In the periodontal ligament fibers, coils down and again it will take back. See, when a force is applied to the crown, the principal fibers first unfold. Okay, ma? Then straighten and then transmit the forces to the alveolar bone. Doctor, you are able to understand? Please understand. You are able to understand me? Okay. When a force is applied to the crown, what happens? The principal fibers first unfold. Once it becomes unfold, at the same time it becomes strengthened. That means strong also. Then what happens? It transmits the forces to the alveolar bone. I already told you, periodontal ligament, the principal fibers mainly Sharpie's fibers between the cementum and the periodontal bone. Naturally, alveolar bone. Naturally, whatever the forces goes directed to the alveolar bone. And elastic deformation of the, and causing the elastic deformation of the bony socket. That is tensional theory. Understood? And then viscoelastic theory. The displacement of the tooth is largely controlled by fluid movements. Okay? Each fibers, inside the fibers, there is going to be the fluid. Okay? So, the displacement of the tooth is largely controlled by the fluid movements with fibers having only a secondary role. These 2 theory you are understood now? Can I go to the next slide? Here. This is the alveolar bone. The 4th part of the periodontium we have come now, right? Alveolar bone. See, this is an alveolar bone on the lingual cortical plate, labial cortical plate and body thing. Here is the alveolar bone which lines the, see here this is a supporting bone. This fully is a supporting bone, that is the alveolar process. So, the alveolar process is from alveolar crest to the apex only. It is only an alveolar process. Below that it is going to be the supporting bone. So internal part, interior part of the bone, what is going to be? Cancellous bone. Okay, there will be a outer cortical, inner cortical bone will be there, and interior part of the bone is going to be the cancellous bone. So the usual question they'll ask is alveolar process extends from alveolar crest to that of the apex of the tooth, and below that it is going to be the supporting bone. In the supporting bone, outer cortical and inner cortical will be there, and in the center it is going to be the cancellous bone. See this, just for the thing I have given. See where there is an alveolar bone proper and there is going to be a supporting bone. And one more thing you should know, see the bone which is lining the socket wall. We should give importance for the bone which lines the socket wall. Why? Because we call it as a lamina dura, which is demineralized when there is going to be a periodontal disease. So whatever periodontitis is present or not, by seeing the X-ray we are seeing only lamina dura. The lamina dura is the one which lines the socket wall. Now periosteum. Surrounding each compact bone is a periosteum. Periosteum is nothing but a connective tissue membrane. So many people they are not understanding what is periosteum. Periosteum bleeds fast, isn't it? Profusely it will bleed. Why? Because it is a connective tissue membrane. Okay. So in case they are asking periosteum, they are putting an MCQ for 4 questions, you have to write it is a connective tissue membrane. Some people will write outer membrane. No, it is a connective tissue membrane. Surrounding each compact bone is a periosteum, a connective tissue membrane. Then what is endosteum? The inner surface of both compact and cancellous bone is covered by endosteum, a single layer of bone cells that separates the bone surface from the bone marrow within. You read clearly. See, periosteum is surrounding each compact bone is a periosteum. Surrounding each compact bone is a periosteum. This is nothing but the connective tissue membrane. Profuse blood supplies, once you enter the periosteum, there will be a blood flow will be more. Okay. Whereas endosteum is inner surface of the both compact and cancellous bone. Okay. The inner surface of both compact and cancellous bone is endosteum. A single layer of bone cell. It is only a single layer of bone cell that separates the bone surface from the bone marrow within. You are able to understand? See, bone remodeling. You know this alveolar bone proper, no? It actually keep on remodel by itself. It's one of the functional characteristic of alveolar bone is remodeling. Whenever there is a functional demand arises, it will get remodeled. It's a continuous process which occurs in the body. Okay, ma? So how this remodeling takes place? Usually we say blood calcium is very, very important for the remodeling of the bone. See, when the blood calcium is reduced, what happens? Parathyroid PTH stimulation starts. Once it is stimulated, there will be a stimulation of osteoblast. So blood calcium, when there is decrease in blood calcium occurs, what happens? There will be a stimulation of PTH. Once the stimulation of PTH, what happens? There is a stimulation of osteoblast. It leukemia inhibiting factor it takes, and what happens? It stimulates the monocytes. Monocytes is the one which will help in formation of osteoclast. Once the osteoclast more in thing, there is automatically there is going to be a resorption. So this cycle you should understand. Decrease in blood calcium stimulates the PTH, stimulation of the osteoblast, leukemia inhibiting factor, stimulate monocytes to migrate into the bone area. Once this monocytes enters into the bone area, it stimulates the osteoclast. Osteoclast, bone resorption, calcium. This whole thing is a circle. Okay, it maintains, homeostasis is maintained. Yeah, at the same time, this osteoblast also secretes interleukin 1 and interleukin 6. It is a pro-inflammatory cytokine. Okay, osteoblast also means the stimulation of osteoblast not only stimulates the monocyte to go into the bone marrow, but also it stimulates cytokines, pro-inflammatory cytokines, interleukin 1 and 6. So what you understood here, stimulation of monocyte to the bone, to migrate to the bone area is very important for osteoclast formation. Yes or no? You have understood, no? See, this cycle but that cycle, everything goes here. Stimulates monocytes to migrate into the bone area. This is the one which creates stimulation of osteoclast. Once osteoclast, naturally there is going to be a bone resorption. This cycle you should understand. Have you understood? Can I go to the next slide now? Let us come to this cementum. Usually, then MCQ they used to ask, what is the blood supply of the cementum? Everyone write different, nothing. It is an avascular mesenchymal tissue. Avascular mesenchymal tissue. So, calcified avascular mesenchymal tissue covering the anatomic root. So, which way the cementum is very important you feel? Because there is a two things, a reversal line and incremental line. These two lines will come only in the cementum. Okay. In cementum, you know, no, towards the crown it is going to be a acellular, towards the apex it is going to be a cellular cementum. So, right towards the apex there is a cellular cementum. Cementum formation, there is a hypercementosis. Why they are getting hypercementosis? Because of the pressure, because of aging. So, cementum, this will give an added strongness to the tooth, isn't it? So, what is incremental line? What is reversal line? You should understand. Incremental line is the line between the cellular and acellular. Okay. Cellular and acellular, between that two, it is going to be an incremental line. What is a reversal line is a line between the already formed cementum to that of the newly formed cementum. இது ரெண்டுக்கும் உங்களுக்கு வித்தியாசம் தெரியணும். சிமெண்டத்துல towards the crown it is going to be a acellular, towards the apex it is going to be a cellular. So usually the cellular cementum will be more, isn't it? At the same time, you should know the two things. One is incremental line, இன்னொன்னு reversal line. Incremental line என்ன அப்படின்னா cellularக்கும் acellularக்கும் நடுவுல இருக்கிறது. It will which will demarcate between the cellular and acellular. The old formed cementum will be there because of the functional demand or anything. The newly formed cementum will come. Between these two, there is a demarcation that is called reversal line. You have understood these two? Right. These are the classifications like acellular, afibrillar, acellular extrinsic, cellular mixed, cellular intrinsic and intermediate cementum. See, acellular cementum covers the root, adjacent dentin, whereas cellular cementum in the apical area. Cellular, apical area and overlying acells are also common in interradicular areas. All these things, the thin cervical layer requires no cell to maintain the viability as the fluid bath. In this, they used to ask you about what is incremental line, what is reversal line, where the cementum will be cellular, where the thing will be acellular, and the fifth one will be vascular or avascular. These five you should be thorough. What are the functions of cementum? Usually when the functions of the tooth, functions of gingiva, functions of periodontal ligament we know, but hardly we are understanding about the cementum function. The cementum is very important, and the primary function itself is anchorage. Okay, that also they will ask in the MCQ. Anchorage is the primary function, and secondary function is maintain the occlusal relationship. What do you understand by maintain the occlusal relationship? Maintaining the occlusal relationship when the occlusal demand increases, hypercementosis, isn't it? So to maintain the occlusal relationship is only the secondary function. The primary is anchorage. And the thickness, this you have to know well. Coronally it is 16 to 60 mu micron. Apically it is 150 to 200 mu micron. That they used to ask in the MCQ. Thus to know whether the apical cementum is more in thickness, more for that only. Okay. And distally thicker compared to mesial aspect. Recently they are asking about that, where the cementum will be thick. Okay. So it is distally thicker compared to mesial aspect. Cemento-enamel junction. Here in MCQ they used to ask which overlaps more. Usually the cementum overlaps the enamel. Always cementum overlaps the enamel. And end-to-end relationship is only 30%. Very rarely cementum and this enamel fails to meet. Okay. So usually the cementum only overlaps the enamel, not the enamel. So you make it into your mind, the enamel doesn't overlap the cementum. Only cementum overlaps the enamel. Very rarely it doesn't meet at all. Okay. This age changes. In gingiva, there will be decreased keratinization, decreased connective tissue cellularity, decreased oxygen consumption, decreased amount of stippling, loss of elasticity, increased width of attached gingiva, increased amount of intracellular substances, increase in number of muscles. Everything will be like this. Okay. Yeah, once there is tooth losses take place, what happens? As long as the tooth is there, you know what is it from the free gingival groove to that of the mucosa. There is no teeth. As the age increases, it is going to be resorbed. The alveolar bone is going to be resorbed. There is going to be mobility, and this gingival thickness and gingival height is going to be minimized. naturally the attached gingiva will be more in amount. And periodontal ligament also, decrease in vascularity, decrease in mitotic activity, decrease in fibroblast, decrease in mucopolysaccharide, everything will be decreased as the age increases. Alveolar bone, there will be a osteoporosis because of more of osteoclastic activity than the osteoplastic activity. Usually to maintain the alveolar bone in a proper way, opposition plus should be the same way. Only then you will have a mating. That's why they used to say the usual common osseous defect which takes place in the periodontium is a horizontal defect. Okay, is a common osseous defect. So there is not going to be a osteoblast. There is going to be more of osteoclastic activity. That is why there is an osteoporosis. And usually in age, as the age increases, continuous deposition of cementum. I told you, no, the cementum had a primary function encourage. When the functional demand arises, there is going to be a hypercementosis. Usually the old age, when they have an untreated tooth, removal will be little difficult because of more of cementum formation. Is that you have understood, everyone? Classification, usually I don't think any question will come, but still you remember that AAP classification is 1999. But usually now, very recently in 2012, there is one more classification has come, that is a recent one. Okay? Then Flemington et al. Would have written a new classification. In International Journal of Periodontology it has come, but we have not yet followed. See here, chronic, localized and generalized, and aggressive, localized and generalized, and periodontal associated with systemic diseases, necrotizing periodontal diseases, abscess of periodontium, periodontal diseases associated with the endodontic development or acquired deformities. All these things will come for classification of periodontics. Let us come to the, I think, classification. Only two questions they can ask you. AAP which year? Any recent techniques have come? Yes, in 2012 in International Journal of Periodontology, Flemington and et al. Have created the new classification. Okay, plaque. And all of you know what is dental plaque. Dental plaque is which is more irritating, plaque or calculus? Plaque is more irritating because it contains viable microorganisms. Usually they will ask more irritating, plaque, calculus, material, alba, food debris. Then you should immediately click plaque, not the calculus, because plaque only contains viable microorganisms. And what is the difference between the plaque and food debris, alba? All other things will be visible, plaque is not visible. Plaque is not visible, okay. So dental plaque is defined as a adherent intercellular matrix composed primarily of proliferating microorganisms along with scattering of epithelial cells, leukocytes and macrophages. Structurally, it is a biofilm of complex and dynamic microbial communities. The dental plaque is more irritating because it contains dynamic microbial community which is more irritating. Okay, because it has a viable microorganisms. This microorganisms releases toxins which will injure the gingival tissue. Understood? And you know supragingival plaque and subgingival plaque is a classification. Supragingival coronal plaque, otherwise called marginal plaque. Subgingival tooth associated, epithelium associated, connective tissue associated and unattached plaque. So the plaque is supragingival plaque and subgingival. Supra will be coronal and marginal, and subgingival will be epithelium, tooth associated, connective tissue associated and unattached. The more dangerous subgingival plaque. Okay, and usually when you are saying about this shape of the plaque, how it will be the appearance, usually the supragingival plaque will have a rosette like appearance, whereas subgingival plaque will have a concave, otherwise bottle brush appearance. Usually they will ask in the MCQ how the supragingival plaque will look like and how the subgingival plaque. Subgingival plaque will look like a bottle brush concave appearance. Same supra will be the rosette like appearance. So how the formation of plaque takes place? First, initially there is going to be a dental pellicle, okay, pellicle, and then over that pellicle the bacteria will get adheres. Growth and accumulation of the bacteria takes place. The formation means these three things you should remember. First is a dental pellicle formation. Over that there is going to be a bacterial adherence, and then only there will be a multiplication of the bacteria takes place. So dental plaque doesn't directly attach to the tooth. It always have a pellicle between the plaque and the tooth. You have understood now? And then in chronic gingivitis, you will have gram-positive organism 56%, gram-negative only 44%. Okay? In gingivitis and this. Let us come to the calculus. Calculus is nothing but the mineralized bacterial plaque. Once the plaque gets matures, mineralized, it is going to be the on the surface of the natural teeth and dental process is classified into supragingival and subgingival. So, the usual question what they ask is mineralized bacterial plaque. Dental plaque. So, you should write about calculus. This is supragingival calculus. Location is coronal to the gingival margin. Color white or whitish yellow. Clay-like consistency. I want you to remember this consistency because usually when the consistency of the calculus, the supragingival will be clay-like, subgingival will be flint-like, F-L-I-N-T, flint. So, you should know the consistency. Supra will be clay-like, subgingival will be flint-like. Okay. So, the white or whitish yellow, hard with clay-like consistency, easily detachable from the tooth surface. Color may be influenced by the tobacco or food pigments. Most common buccal surface of the maxillary molar and lingual surface of the anterior teeth. Why? Maxillary secretions and lower parotid cell secretions will be there. Lower will be sublingual and this thing. So, the more amount of calculus will be the maxillary surface of the posteriors and then lingually mandibular area. There will be more amount of calculus will be there. This supragingival calculus will be clay-like consistency. These are things you should remember in that. Subgingival, below the crest of the marginal gingiva. See, they open the flap and then they are showing it subgingivally. Okay. See, it is below the crest of the marginal gingiva. The color will be hard and dense, dark brown or greenish black. The microscopic studies reveal deposits of subgingival calculus near to the base of the pocket, but do not reach the junctional epithelium. Please remember, it is at the base of the pocket, but do not reach the junctional epithelium. It do not reach that's very, very important. Okay, do not reach this. After the removal of calculus, a reduction in gingival inflammation and probing depths with gain in clinical attachment can be seen. Understood? So, what is gingival and what is subgingival you should know. What is the consistency you know, and where the calculus will be you know. Usually people are writing below the CE junction subgingival, not that, not below the CE, you should write below the crest of the marginal gingiva. Below the crest of the marginal gingiva, it will be dark brown or greenish black and it is attached firmly to the tooth surface. To show that only that figure is there. Can I go to the next slide now? So, calculus attachment to the tooth surface. Attachment by means of an organic pellicle on enamel, number 1, and mechanical locking will be there in irregularities, and close adaptation of calculus undersurface depression to gently sloping mounds of the unaltered cementum and penetration of calculus bacteria into the cementum. So, in the cementum itself two attachments, one is into the cementum, penetration of calculus bacteria into the cementum, one, and second thing, close adaptation of calculus undersurface of the depressions or gently sloping mounds which is present in the cementum. So, this calculus embedded deeply into the cementum may appear as a calculocementum. This they can ask you in the MCQ. What is calculocementum? The calculus embedded deeply in the cementum may appear morphologically similar to the cementum and it is termed as calculus. So, calculocementum does not look like a subgingival calculus, it will look like a cementum. Understood this? Is a possible question here is calculocementum. Okay. Can I move to the next, doctor? Now, let us come to the host response. Saliva acts as a vehicle for swallowing bacteria, inhibits the attachment of bacteria and kills the bacteria by peroxidase metabolism, lysosome and lactoferrin. See, the saliva is a very, there are two types of saliva will be the whole saliva. Whole saliva in the sense everything together, including the GCF liquid and all other things, the whole saliva. Usually when we are doing a research, they will ask about the whole saliva or saliva. Whole saliva in the sense early morning in an empty stomach, you give a bit of paraffin, ask them to munch without in an empty stomach, they should not take anything and then munch. The saliva which comes out is a whole saliva, it contains everything. Okay. So, when this saliva acts as a vehicle for swallowing bacteria. So, how this bacteria get metabolized or by means of peroxidase system, okay, and lysosome and lactoferrin. So, the role of epithelium in host response, structural arrangement of cells prevents bacterial entry. I already told you when I am talking about keratin atta gingiva, the keratinization resists trauma. And when I am talking about junctional epithelium, I said it is a permeability barrier. The saliva, see, the saliva acts as a vehicle for swallowing bacteria, inhibits the attachment of the bacteria. So, swallow panana, there is not going to be anything, and kills the bacteria by peroxidase. How do you say this kills the bacteria by peroxidase? How do you say this kills the bacteria by peroxidase metabolism? Saliva has so many enzymes, isn't it? Saliva has so many enzymes. There are 17 enzymes are present in the saliva and the gingiva. These enzymes will metabolize this bacteria. So, there is not going to be a disease formation. So, that is why they say saliva acts as a vehicle. So, usually they have a more of salivary formation, no? The calculus and plaque will be very minimal because washes out everything. Killing mechanism of neutrophils, non-oxidant dependent metabolism, non-oxidative metabolism, macrophages, phagocytes and kills the bacteria, removes damaged host tissue during inflammation. In that you are supposed to remember about complement activation pathway. Now let us come to the trauma from occlusion. Okay. Here the trauma from occlusion we call it as a margin of safety. So margin of safety portrait, they will give diseases in thing. You should write about trauma from occlusion is only a margin of safety. When the occlusal force exceeds the adaptive capacity of the tissue, injury results. The resultant injury is termed as trauma from occlusion. So, the trauma from occlusion is a tissue injury. Okay. When the occlusal force exceeds its normal adaptive capacity, what happens? There will be a tissue injury. This, when the trauma from occlusion question comes, you should remember about tissue injury. Okay. So, when occlusal forces exceed the adaptive capacity of the tissues, tissue injury results. The resultant injury is termed as trauma from occlusion. This trauma from occlusion refers to the tissue injury, not to the occlusal fold. Underline that it is not to the occlusal. Whenever they are talking about trauma from occlusion, you should remember about the tissue injury, not to the trauma from occlusal forces. Okay. An occlusion that produces such an injury is called traumatic occlusion. You should understand three things: trauma from occlusion, traumatic occlusion, occlusal trauma. These three difference you should be there. Trauma from occlusion is nothing but a tissue injury, and this occlusal force is nothing but a, thus the trauma from occlusion refers to the tissue injury and not the occlusal force. So, occlusal force ko trauma from occlusion ko sambandhame kedayadu, and an occlusion that produces such an injury is called as traumatic occlusion. Are you able to understand? Traumatic occlusion is a occlusion that creates an injury. Trauma from occlusion is a tissue injury. There is trauma from occlusion to the tissue injury, not to the occlusal force. So, you remember, you are able to understand these three. Usually, the people used to get confused in these three. There are two types there. One is acute and chronic, and other one is primary and secondary. Okay. Acute trauma from occlusion results from abrupt occlusal impact on the force. For example, biting something suddenly. That is an occlusion, abrupt force. And chronic trauma from occlusion develops from the gradual changes in the occlusion. So, acute is because of abrupt contact between the two teeth by means of any object, and chronic is gradual changes. So, acute trauma from occlusion results from abrupt occlusal impact. Force such as biting a hard subject, and the tissue injury, you will get a trauma from occlusion. And high restoration of prosthetic appliances that interfere with or alter the direction of occlusal forces on the teeth. Signs and symptoms: tooth pain, sensitivity to percussion, increased tooth mobility. So, these three things: tooth pain will be there, sensitivity, percussion will be there, tooth mobility will be there. These three are there. You can think about trauma from occlusion. Chronic. Chronic trauma from, already I told you when I am telling about chronic trauma from occlusion, because of the gradual changes in the occlusion. So, it is a more common and develops from gradual changes, occlusal wear, drifting movement, extrusion, parafunctional habits such as bruxism and clenching. So, here you should remember in MCQ they can ask bruxism may be due to you should write, they will give chronic, acute, primary, secondary. You should pick chronic trauma from occlusion. Okay. Then there are another type I told you, primary or secondary. See in the primary how it is and secondary how it is. There are three stages are there, injury, repair and adaptive remodeling of the periodontium. There are three stages in the trauma from occlusion, injury, repair and remodeling. Usually, wherever there is a pressure, there will be two things on the bone. One is pressure or the tension. When there is a pressure, there is going to be a resorption. Constant pressure there is a resorption. When there is a tension, there is going to be a opposition. That is the usual thing, how the coupling takes place in the bone because of the opposition and the resorption both interconnected. Whenever there is a pressure, there is going to be a resorption. Wherever there is an opposition, tension, there is going to be a opposition. Understood? So, the greater pressure results in compression of periodontal ligament fibers. Already I told you in periodontal ligament fiber there is going to be a fluid, isn't it? Viscoelastic fluid will be there. It is compressed now. Injury to the fibroblast and other connective tissue leading to necrosis of the ligament. When there is a pressure on the periodontal ligament, what happens? The fibroblast, other fibers gets necrosed. There is going to be a necrosis of the periodontal ligament. There will be a vascular changes. Increased resorption of the alveolar bone. Resorption of the tooth occur. So you remember, wherever there is a pressure, not only a resorption of the alveolar bone occurs, there is also a resorption on the tooth surface occurs, apart from necrosis of the periodontal ligament. Why there is a necrosis? Because of the pressure, fibroblasts and fibers get compressed. Vascular changes takes place. That fluid will come out. There is going to be a necrosis. All these things on the pressure side. And on the severe tension, what happens? Widening of the periodontal ligament. Isn't it? I told you on that when I am telling about the theory, I said first it unfolds, then becomes strength, then only it passes the pressure to the alveolar bone. So when there is a tension, there will be a widening of the periodontal ligament, thrombosis will be there, hemorrhage, tearing of the periodontal ligament, then only the resorption of the alveolar bone comes. Understood? In trauma from occlusion, when the pressure comes, all these things occurs. When tension comes, all these things occur. You remember, in periodontal ligament, when there is a pressure, there is going to be a necrosis. When there is a tension, there is going to be a widening of the periodontal ligament. Okay. Influence of trauma from occlusion on progression on marginal periodontitis. So you should remember, the trauma from occlusion does not give pocket or gingivitis, isn't it? Already I told you, when the tissue exceeds the normal capacity to withstand, only you are getting a tissue injury. Because of the tissue in a trauma from occlusion, that only we call it as a tissue injury. In that tissue injury, what happens? There is a chances for pocket formation or not, means there is not going to be the pocket formation. Trauma from occlusion does not cause pockets, that usually they are asking in MCQ. And it doesn't cause gingivitis also. Why it doesn't cause gingivitis? Trauma from occlusion, normally there is not going to be gingivitis. The patient will have a firm, nice gingiva, and when there is a pocket, there is not going to be a pocket. At the same time, there will be a resorption, tooth mobility will be there, pain will be there. Why? Because the blood supply of the gingiva is not affected at all. Blood supply of the gingiva is not affected. The investing tissue is not affected in the trauma from occlusion. Only the supporting structures are affected. Okay, what? This usually they are asking in MCQ. See, the bacterial plaque initiates gingivitis and results in the periodontal pocket formation, which affects the marginal gingiva. So, the marginal gingivitis occurs only because of the bacterial plaque, not from the trauma from occlusion. But trauma from occlusion affects only the supporting tissues and does not affect the gingiva. Okay? And marginal gingiva is unaffected by trauma from occlusion. Why means? Because its blood supply is not affected. Even when vessels of the periodontal ligament are obliterated by the excessive force. In trauma from occlusion, you have to understand this very, very clearly. There is no gingivitis, there is no pocket formation because the blood supply is not affected. Only the supporting structure, periodontal ligament, blood supply is affected. Understood? Clear? So, usual question they will ask, trauma from occlusion gives pocket or not? No. Gingivitis or not? No. So, what is the treatment? Usually coronoplasty. Management of parafunctional habits like bruxism And in case there is a mobility, you can do splinting, orthodontic tooth movement, occlusal reconstruction, extraction, etc. Usually in trauma from occlusion, coronoplasty will be the best answer. Then we will come to the halitosis. Unpleasant odor exhaled during breathing is called halitosis. Okay? So usually there are two things will be there, oral causes and non-oral causes. Most of the time the halitosis is mainly due to oral causes, 90%, less only extra oral. So extra oral means you can include because of the systemic origin. These are the causes for physiological halitosis: mouth breathing, medication, aging, fasting, tobacco, foods and alcohol. So measurement, in this you should understand two things is very, very important, they will ask you. The organoleptic method is a gold standard. That's a usual question they are asking in the PG entrance. The gold standard is organoleptic. And one more thing they can ask you, gas chromatography. Which way the gas chromatography is important means, in case the halitosis is from the non-oral causes, that time if you write organoleptic, they won't give a mark. You should write gas chromatography. Organoleptic on the gold standard, that's true. But when it is a non-oral causes of halitosis, this gas chromatography will be the best one. Okay? And other methods are halimeter, Barnett test and chemilutions. Halimeter they are using also. Okay? Even generally in other clinics they are using halimeter. So the possible two questions will be non-oral causes can be measured by gas chromatography. Organoleptic will be the gold standard. I mean your people are able to understand me thoroughly. Anywhere means you stop me. Now pathogenesis of periodontal disease. Usually you should understand how the periodontal disease comes two ways. One is direct and one is indirect. Direct is by means of the bacterial plaque. This bacteria releases endotoxins which enters the gingival sulcus, goes via the junctional epithelium, enters the connective tissue, releases the pro-inflammatory cytokines, then there is a destruction like this. That is direct. Direct sulcus valiya vandrum. இன்னொன்று only depends upon the host. If the host is not willing to withstand all this stress, then there is a chances for the disease. We treat that by means of host modulating therapy. One is by evading the microorganism, evading the gingival sulcus and releasing the toxins and enters through the junctional epithelium where there is a permeability and enters the connective tissue and there will be a pro-inflammatory cytokines release, connective tissue destruction takes place, then there is a periodontitis. And other one by means of the host, evading the host mechanism. That is only I have written this. See, bacterial challenge releases LPS. LPS is nothing but endotoxins. Okay, and then host immune and inflammatory response. Cytokines are released. I told you, cytokines, pro-inflammatory cytokines, interleukin 1, interleukin 6, tumor necrosis factor. All three are pro-inflammatory cytokines. And then there will be a connective tissue and bone metabolism get affected. Only then there is a clinical signs of periodontal disease comes. Are you able to understand this? See, the environmental risk factor and genetic risk factor, both are added effect over there. Okay. Pathogenic bacteria and susceptible host. If these two only results in periodontal, that's what I told you. One is direct pathogenic, one is evading the host. See, these are the complexes. The red complex is P. gingivalis, P. fortissus and denticola, and this is orange one, rectus, and there will be yellow and green and violet. These are the, violet we will call it as a purple complex, isn't it? These are the subgingival microbial complex. Why at all red is given to that? Can you answer me? Why there is a red complex P. gingivalis? The bleeding from gums is mainly because of P. gingivalis, isn't it? Because gingivitis. And most of the time the periodontitis, chronic periodontitis is mainly because of P. gingivalis. So bleeding from gums, so it is green. Usually this Campylobacter rectus, all these things will be in that, and that the Peptostreptococcus micros will be more in periodontal abscess. Peptostreptococcus, that is usually they are asking in the entrance exam. Okay, Peptostreptococcus micros will be more in periodontal abscess. See, usually this orange, this is all early colonizers, like yellow, green, these are all early colonizers. They can ask you, why you are telling P. gingivalis is bleeding on gums? Because it is a late colonizer. Once the bacterial colonize is more co-aggregated, secondary colonization occur, only then the destruction occurs. Immediately after the bacteria enters, it is not going to be a bleeding. But in the advanced stage only you are going to get the bleeding. So the red complex is mainly because of late colonization of those bacteria, whereas this green and yellow, these thing is going to be the early colonization. This orange complex, it bridges the early and late. This usually they will ask in the entrance exam. See, these are all early colonizers. That is only the late colonizing thing. And between this orange, red and yellow will be bridged by means of the orange complex. They can ask you why there is a bleeding on red complex. You can say one, it contains P. gingivalis. Second thing, it is a late colonization, because in advanced established gingival lesion only you are going to get the bleeding. So this is early colonizing. Orange and red is going to be the late colonizing thing, and the orange is going to mediate between the early colonizer and late colonizer. Is that understood now? Right. This is a mode of periodontal disease. Specific bacteria, pathogenic bacteria enters the host thing, releases LPS and antigens, and there is going to be a release of cytokines, connective tissue destruction takes place. Only then you are going to get the. Now, how this periodontal disease? You know, no? The periodontitis is always associated with CVS, respiratory and diabetic. So, how at all this cardiovascular disease and periodontal disease is interconnected? Systemic or periodontal infection, what happens? There will be a increased fibrinogen, and there will be an increased white blood cell count, and there will be a von Willebrand factor also will be increased. All these three things will be increased. There will be a increased blood viscosity. Once the blood viscosity is increased, naturally there is going to be a ischemic heart disease. Okay? Actually, people doesn't understand why there is a these things are interconnected. If you go and see, tell it to the cardiologist, I don't think they will easily understand. But really what happens is because of the periodontal infection, fibrinogen gets increased in amount, white blood cells increased amount, von Willebrand factor will get increased. Because of that, what happens? The blood viscosity also increases. Once the blood viscosity increases, there is going to be a ischemic heart disease. Have you understood this? One more thing, the periodontal infection, gram-negative bacteria, all of you know the periodontal infection is only because of gram-negative. When I told you about gingivitis, I told you more than 50% gram-positive, whereas in periodontitis, only about gram-negative. Okay? In gram-negative, some microorganism will secrete LPS endotoxin, some will secrete exotoxins. Okay? So here the gram-negative bacteremia with LPS endotoxin, what happens? Endothelial damage takes place, and platelet adhesion aggregation takes place, and monocyte infiltration and proliferation takes place. So epithelial damage, endothelial damage, you know, the blood vessels, endothelial should be in a correct same line. In case there is a gap, there is a leakage, isn't it? And there is a platelet adhesion and aggregation takes place. Monocytic infiltration. What happens when the platelet adhesion takes place? Thrombus-like formation takes place. And cytokine and growth factor production and thrombus formation. It results in atheroma formation, vessel wall thickening, and thromboplate events will be there. Okay? Atheroma formation, vessel wall thickening, thromboembolic events will be there. So you remember, before that I told you, periodontal infection gives increase in fibrinogen, increase in WBC cell count, increase in von Willebrand factor. So what happened? All these together, increase in the blood viscosity. Once that increase the viscosity, there is going to be ischemia of the heart disease. Here the periodontal infection, the more of gram-negative microorganisms and more of endotoxins. When it releases, what happens? Endothelial damage takes place. There will be a platelet adhesion and aggregation. Then monocytic infiltration will be there, and cytokine and growth factor production will be more, and as a result there is going to be a thrombus formation. Once the thrombus formation is there, there will be a atheroma formation, vessel wall thickening, thromboembolic events. You have understood? Can I go to the next one? See this. How the atheroma formation takes place. Same. See, periodontal disease, when it goes cytokines and pathogens and LPS, cytokines like pro-inflammatory cytokines, pathogens like P. gingivalis and other things, and LPS, the endotoxin. When it goes to the liver, what happens? The CRP level increases. CRP is what? C-reactive protein, that gets increases, and pro-inflammatory interleukin 6 get increases, there will be an increased fibrinogen, okay, and there will be a thrombus formation, then there will be an atheroma formation. You have understood this? Can I go to the next one? So, I want you to understand between the ischemic change and atheroma formation, okay. In diabetic, usually they say diabetic and periodontitis is a two-way relationship. Those who are having a periodontitis, there is a wide chance for diabetic. Those who are having diabetic, there is a wide chance for periodontitis. That is because there will be thickening of the vessels takes place. There is no proper blood supply to the gingiva and other supporting structures. Naturally, they will be having a periodontitis. See, periodontal infection, inflammatory mediators, bacterial products, bloodstream enters, liver and pancreas, there will be insulin resistance and glucose tolerance and diabetic. So, both the way it is related. Pregnancy outcome. So, bacterial infection, what happens? There will be a bacteria and products in the amnion enters, inflammatory response with cytokine production in amnion, increased amniotic prostaglandin production, preterm. Understood? Here, you remember there when we are talking about CVS, you remember about the increased fibrinogen, all other things, blood viscosity and increased fibrinogen, there will be a thrombus formation and atheroma, all those things. Whereas here, the pro-inflammatory cytokine, what happens? Inflammatory response with cytokine production in amnion itself. All these pro-inflammatory cytokines will be there in the amnion when there is a periodontal disease. So, as a result, there will be an increased amniotic prostaglandin production, preterm labor. Understood? See, I have given in one thing with atherosclerosis and cardiovascular disease, diabetics and preterm low birth weight and respiratory. Periodontal tissues, pathogenic bacterial flora, release of bacterial proteinases. All these time I was telling about exotoxin, endotoxin, exotoxin, endotoxin. Here there is a bacterial proteinases is released. Okay. So, activation of complement component takes place, recruitment and activation of neutrophils comes there, then frustrated phagocytosis takes place, and release of neutrophil proteinase and abnormal connective tissue destruction takes place. As a result, there will be a periodontitis on this side, on the lungs that is going to be emphysema. All this time I was telling about pro-inflammatory cytokines, endotoxins, exotoxin. Okay, that is other diseases. Whereas now in respiratory, the bacterial, pathogenic bacterial flora releases bacterial proteinases. This you underline that. Okay, and when it comes to the periodontitis with the respiratory disease, you give importance for bacterial proteinases. Okay. Smoking and periodontal disease. Clinical features, there will be a decreased gingival inflammation, decreased bleeding on probing, increased prevalence and severity of periodontal destruction. Microscopic structure, increased production of inflammatory mediators, diminished fibroblastic function, altered reparative and regenerative potential of periodontium. You please try to understand, in smoking there is altered reparative and regenerative potential of periodontium. Usually we say in smoking patients, even though they are having periodontitis, bleeding and probing will be minimal or no, isn't it? That is because altered reparative and regenerative potential of the periodontium and diminished fibroblastic function. Okay. Want to write? Increased levels of periodontopathic organisms, namely Forsythus, gingivalis and AA and others. Smoking status should be considered in diagnosis, prognosis and treatment planning of periodontitis patient. Why? It is one of the, why we should give importance for this? What type of risk factor? Environmental risk factor. So they can give smoking risk factor, environmental, genetic, then you should write it is an environmental risk, only then they will give a full mark. Okay? It is an environmental risk factor. My main organism will be bacteria, Forsythus, P. gingivalis, AA. So any periodontitis you will remember P. gingivalis and AA. When it comes to smoking, you please remember bacteria, Forsythus. This is I told you before, isn't it? Same thing. See, healthy gums, gingivitis and periodontitis. In periodontitis, there is attachment apparatus is involved, and gingivitis only marginal gingiva is involved. This is gingivitis and defense mechanism of the gingiva. This is mainly because of the gingivo-clavicular fluid. And methods, you know, observing papers, twisted strips, twisted threads, micropipettes, intraclavicular washings, and there are two types will be there, intraclavicular and extracellular. Composition, cellular elements, organic compounds and electrolytes. Drugs in gingival clavicular fluid, that's more important here. Why we are giving important for drugs in clavicular fluid is, most of the time when you are giving a therapy, like medicines you are going to give, for example tetracycline you are going to give, instead of giving systemic, if you give local drug delivery, its level in clavicular fluid will be higher than that of the serum. Okay, certain drugs that levels will be higher, therapeutic level will be higher in the clavicular fluid than that of the serum. That is why we are giving more importance for a drug which can be given via clavicular fluid. See, drugs in gingival clavicular fluid, drugs that are excreted through the GCF may be used advantageously in periodontal therapy. Tetracyclines are excreted through GCF. Metronidazole is another antibiotic that has been detected in human disease. There are two types of antibiotics which can be seen in the clavicular fluid. One is tetra, other one is metro. The tetra will be, the clavicular fluid level of tetra will be higher than that of the serum level. Gingival inflammation, the stages will be initial, early, established and progression from gingival health to the periodontitis. This is clinically and histologically. Pristine condition, clinically healthy, early gingivitis, then only it comes to the chronic periodontitis. Histologically health, initial, early, advanced. The gingivitis stages what you are giving is a histological stages, not the, see the clinical features. Depending on the course and duration, acute, subacute, recurrent and chronic. Depending on distribution, it is marginal, papillary and diffuse. Depending on the localization, it is localized and generalized. These are the different type of gingivitis. So, any disease gingiva, you know, the color will be changed, there will be a bleeding on probing, consistency will be edematous and changes in the size, there will be an enlargement, surface structure will change, position will change and contour. Usually, the margin of the gingiva will be, usually how the margin of the gingiva, it will be knife-edge. When there is an inflammation, it will be rolled out. Okay. Enlargement, again there is a difference, increase in size, type acute or chronic. Category drugs associated anticonvulsant and calcium channel blockers and immunosuppressant. These are the things which will give gingival enlargement. And here, so when it comes to a drug associated, for example, the patient is having epileptic, you will be giving phenytoin, isn't it? What will happen when you give a phenytoin? The collagen turnover rate will be high. Because of the turnover rate of collagen high, you will have a collagen bundles. Thick epithelium will be there. In the connective tissue, the collagen bundles will be more and it is sequentially arranged. Okay. So, the gingiva will be firm, fibrous, edematous. Okay. So, what you will do means, see whether the patient is responding properly or not after doing the non-surgical therapy. If they are not responding, you can take the physician opinion and you can change the drug. Same way you can do when the patient is having a hypertensive, anti-hypertensive drug and the patient is having a renal failure, they will be having a medicine cyclosporine. For those patients, you take the physician opinion and change the drug. Definitely the collagen level turnover will be reduced and there won't be any enlargements. See, drug substitution, surgical therapy. Acute gingival lesions, acute necrotizing ulcerative gingivitis, herpetic and pericorneal. All these three will be acute gingival lesion. In that, once you change the drug, it will take 6 months to 1 year for metabolization of already existing drug, only then it will show the change, not immediately. But you will have a change definitely, but it will take 6 months to 1 year for metabolization of already existing drug in the body, only then it will show. And here, the acute gingival infection is an acute necrotizing primary hepatic and pericorneal. Apart from that, we can include even a gingival abscess in acute gingival lesions. Okay. And you know, no, gingival abscess is confined to the margin of the gingiva. It is not with the attachment, it is only to the margin, and mainly because of the any trauma. And oral lesions, punched out crater-like depression at the crest. All these things will come for acute necrotizing ulcerative gingivitis. The main important thing is punched out appearance. Punched out crater-like depression, in the crest of the interdental papilla. I want you to understand acute necrotizing ulcerative, it initiates in the interdental papilla only. It starts from the interdental papilla. The same way where I told you about drug-induced gingival enlargement, there an anticonvulsant drug when you give, there also enlargement starts straight from the interdental papilla. Then only it comes to the marginal gingiva. Okay. Whereas in drug-induced gingival enlargement, in case it is an idiopathic, the enlargement will be with the attached gingiva also. It doesn't confine to a marginal gingiva or interdental, it is to the attached gingiva also. When there is a gingival enlargement in marginal, interdental and attached, you can say it is a idiopathy. When it starts from the interdental papilla like bead-like enlargement, then comes to marginal gingiva, you can say it is a drug-induced gingival enlargement. Same way, in necrotizing, mainly punched out or crater-like depression in the interdental papilla first. Okay. And crater covered by a greyish pseudomembrane. Patient will have a pain, radiating pain they will be having, pasty saliva will be there, metallic saliva will be there, metallic taste will be there. Because of the thick saliva, the washing is not possible, isn't it? So I already told you, saliva is a vehicle. That is not there because it is a pasty thing. So the patient will have a metallic taste. In one more case, there will be a metallic taste for the patient. Can you remember and tell me? The patient is, which drug? Metronidazole. So, the metallic taste means you remember two things. One is with the metronidazole and other one is with the acute. In case the patient is not having any infection but still having, you can ask whether you are taking a metronidazole. In case the patient is having a metallic taste with a metronidazole and there is, you have to give a metronidazole. What is the drug of choice? Drug of choice for metronidazole? You know, tell. Tinidazole, isn't it? And primary hepatic gingival stomatitis, viral infection characteristic by diffuse erythema and vesicular eruptions will be there. So in MCQ entrance, they can ask vesicular eruption present in anag, herpes, pericorneal, gingival abscess. You should write herpes. Herpes is the only infection where there is a vesicular eruption will be there. Punched out crater is present only in acute necrotizing ulcerative gingivitis. And other one is pericorneal is an acute infection which refers to inflammation of the gingiva and the surrounding soft tissue of an incompletely erupted tooth. Incompletely erupted tooth is pericornealitis. Desquamative, what is the other name for desquamative gingivitis? Gingivosis. Okay. So, what is the other name is? It is gingivosis. So, chronic desquamative gingivitis is characterized by intense red desquamation of the surface epithelium of the marginal and attached gingiva. By reading this, are you able to understand anything? There is a desquamation of the surface, intense redness in the epithelium of the margin and attached. Idhe mari vera idhiliyad varuma, but not involving the attached. There will be a intense red in the margin of the gingiva. Patient will have burning sensation, but it is not desquamatic. What it would have been? Atypical gingivitis, plasma cell gingivitis also you will have, isn't it? The difference between that, here you will be having a peeling of the thing, there won't be, and here it will be involved with the attached gingiva, there mostly involved with the marginal gingiva. Here because of the stress and other things, there only because of the allergy. புரியுதா அந்த டிஃபரன்ஸ் தெரிஞ்சாதான் உங்களுக்கு எழுதுறது ஈஸியா இருக்கும். See, chronic desquamative gingivitis is characterized by intense red and desquamation of surface epithelium of the margin attached. And treatment will be removal of the plaque and topical steroids and severe cases systemic immunosuppressants. And periodic recall and follow-up is the most important part of the management. Potuma, Matita? This is periodontal disease, I have already told you. pocket. The periodontal pocket defined as a pathologically defined gingival sulcus. It is one of the most clinical feature of the periodontal disease. So, உங்களுக்கு பாக்கெட்னா என்ன ஞாபகம் வரும்? ட்ராமா ஃப்ரம் அக்ளூஷன்ல பாக்கெட் கிடையாது, periodontal extensions மட்டும் தான். This is 5 zones can be at the bottom of the pocket. Clinical features. Now we will see why there is a discoloration. What are the clinical features? What is the reason for that clinical features? See, bluish red discoloration of the gingival pocket, flaccidity and smooth and shiny surface. Why? Due to circulatory stagnation. So, periodontitis there is a bluish red. Why? There is a circulatory stagnation. And due to destruction of gingival fibers only, you are not getting a firm gingiva. Gingival firm or more. Periodontitis it is not firm. Okay, that is because of destruction of gingival fibers. A smooth, shiny surface. Usual clinical feature is stippling will be, isn't it? And the stippling irukadu periodontitis. Smooth avum, shiny avum. Yen keta atrophy of the epithelium and edema. Pitting on pressure due to edema and degeneration. So, these are the clinical features that are the causes. And gingival wall may be pink or firm. When fibrotic changes predominate, fibrotic changes more naturally what will happen? There will be a over exudation and degeneration. Bleeding on probing due to increased vascularity, thinning and degeneration of epithelium, the proximity of the enlarged blood vessels in the inner surface. Then probing is generally painful. Why? Because there will be in periodontitis, there will be ulceration in the inner wall of the periodontal pocket. And pus may be present due to suppurative inflammation of the inner wall. You have understood now? These are the clinical features of the periodontitis. What are the causes? Usually, why there is a bleeding on probing and pain is because of the ulceration of the inner wall of the pocket. That is the first. Second, only increased vascularity, thinning of the epithelium, all other things. Okay. How do you eliminate? SRP, gingival curettage, gingivectomy, ENAP and periodontal flap surgery. Already I told you, the osseous defect, the most common osseous defect is horizontal. Responsible for bone destruction, chronic gingival inflammation, trauma from occlusion and combination of both. Bone destruction pattern in periodontal, these are the different patterns. Horizontal, vertical, craters, bulbous bony contours, reverse architecture, ledges and furcation environment. Do you know any name for a ledges? Any other name is for ledges? What is lipping, buttressing bone formation? This is chronic periodontitis. Depends upon the severity, you can take it into mild, moderate and severe, and this disease is mainly because of P. gingivalis. Okay. Risk factors, plaque and plaque retentive factors, systemic diseases like diabetic, environmental factors like smoking, genetic factors, no clear determinants are there. Understood? Aggressive, already you know it is aggressive will be localized or generalized, and when it is come, and one more classification is rapidly, and this aggressive periodontitis you call it as a localized when it is involved only with the molar and incisor. More than 30% of the site you will call it as a generalized. When the aggressive periodontitis is not treated at all and they are coming to 30 to 35 age, loss of teeth will be there, 1 or 2 teeth will be present, you call it as a rapidly progressive periodontitis. And here there will be a more rapid bone loss. Why there is a more rapid bone loss in aggressive periodontitis than the chronic? In chronic I told you apposition and resorption will be maintained, whereas here resorption will be more. Why means because of the exotoxins released by AA. The AA releases more of exotoxin. AA is an anaerobic bacteria. It releases exotoxins. It grows faster in the subgingival apical area because it gets a proper environment to grow. So there will be a more of resorption than the apposition. That is why there is a vertical or angular bone defect in the aggressive, and rapid bone loss is present. When it is not treated in time, there is a rapid loss of tooth, and we call it as a rapidly progressive periodontitis. Understood? This is necrotizing ulcerative periodontitis. It may be the extension of necrotizing ulcerative gingivitis. Here there will be leading to periodontal attachment and bone loss will be there. Pockets are not found. You remember? Pockets are not found because of a ulcerative and necrotizing nature of the gingival lesion, marginal epithelium, connective tissue and gingival. So, you remember where there is no pocket formation, one I told you in trauma from occlusion. Second thing, necrotizing. See, in pockets are not found because of the ulcerative and necrotizing nature of the gingival lesion. Gingiva necrotize illaya. So, necrotizing ulcerative periodontitis is distinguished from necrotizing ulcerative gingivitis by more severe condition with periodontal attachment and bone loss. When you call it as a necrotizing ulcerative stomatitis, larger area of soft tissue necrosis with exposure of bone and sequestration of bone fragments. This type of severe progressive lesion with extension into the vestibular area. When the necrotizing ulcerative gingivitis is not treated, go to periodontitis. When the periodontitis extend to the vascular area, you will be getting a stomatitis. You should understand necrotizing ulcerative periodontitis involving the vestibular area, we call it as a stomatitis. And patients with necrotizing ulcerative periodontitis were more likely to have CD4 counts below 200 cells per cubic millimeter. Please note it, they are asking in the entrance. Usually the patients with NUP were more likely to have CD4 plus counts below 200 cells per cubic millimeter. Shall we go to another one? Refractory periodontitis. Those cases that do not respond to any treatment. Appa, am I faster? I am too fast? You are able to? Right. Say refractory periodontitis. Those cases that do not respond to any treatment provided, whatever the thoroughness or frequency is termed as refractory periodontitis. Those cases that do not respond is refractory. That is only refractory. What is recurrent periodontitis then? This is refractory. See, those cases that do not respond to any treatment, you call it as a refractory. It can be differentiated from a recurrent periodontitis cases in which after the remission of disease, recurrence follows due to inadequate plaque control. If you are not doing it properly, then what you are getting, the patient will come again with a periodontitis, we call it as a recurrent. Refractory is not responding, recurrent is not doing the treatment properly. So, recurrent is mainly because of the surgeons, okay, whereas the refractory is mainly depends upon the not responding, that is post. Understood? You should know the difference between the recurrent and refractory. AIDS associated, HIV associated periodontitis, necrotizing stomatitis, HIV, necrotizing, these are a different type of disease. Common oral thing, you know, oral leukoplakia and oral candidiasis, Kaposi sarcoma. The main important things I want you to know here in MCQ entrance, what they will ask is atypical ulcers and defect in wound healing. So, in HIV associated periodontitis or gingivitis and HIV associated lesions, you will be having a atypical ulcer, okay, atypical ulcers and delayed wound healing. AIDS and the periodontium, distinct types of periodontal diseases associated with the HIV infection are HIV associated gingivitis, HIV associated periodontitis, necrotizing stomatitis, HIV necrotizing stomatitis. In that, the common oral periodontal manifestation in dental part of view where we are going to give more importance is atypical ulcers and delayed wound healing. Now we have come to diagnosis. Periodontal diagnosis is very, very important. Unless you diagnose the disease properly, you cannot do the treatment planning. Unless you do the proper treatment planning, you cannot do any treatment on the patient which will show prognosis. Okay? So, principles of diagnosis is mainly sensitivity, specificity, predictive value. These three things are very, very important to diagnose. So, factors to consider when making diagnosis. You write a case sheets, no? In that, the BPE is used as a screening tool only. What do you understand by this? It is used only as a screening tool. What is BPE? Bleeding on, probing on, examination, that's all. with that you cannot decide the disease. You can say this is only the screening tool. Okay, the patient is having a bleeding and probing. Let us see what type of disease he has. So it is a screening tool. In case they can ask you in MCQ, you should write this is a screening tool. It is not a diagnosis. It is only a screening tool. In mobility, there is a grade 1 mobility, grade 2 mobility and grade 3 mobility. When will you say it is a mobility? Beyond the physiological range, it is termed as pathologic or abnormal. So, the mobility can be physiological tooth mobility or pathological tooth mobility. In pathological, when it goes beyond the physiological range, you call it as a pathological tooth mobility. The tooth mobility by means of Miller's index we will find out grade 1, grade 2, grade 3. So, when the examination of periodontium comes, you should do plaque, calculus, gingival examinations, periodontal pockets. Okay. Peri-implantitis, probing around implants. Peri-implantitis can create pockets around implants. Okay. You should know the difference between peri-implantitis and peri-mucositis. Peri-implantitis is around the implant. Peri-implantitis can create pocket around implants. Plastic periodontal probe should be used to prevent scratching of the implant surface instead of the usual steel probe used for the natural dentition. This they can ask you in MCQ, plastic probes. Peri-implantitis can create a pocket. Okay. Then prognosis, it is a prediction of the probable course, duration and outcome. That also they can ask you in MCQ. It will predict the course, duration and outcome of the disease. When you take one case, you do the treatment, you will know whether this treatment will be good or not. For example, the patient is having a grade 1 mobility, you are doing only scaling, definitely that is not going to be a prognosis. If you do SRP, added to the scaling, you do root planing also, definitely there will be a prognosis. Okay? So, this prognosis is a prediction of the probable course, duration and outcome of the disease. Remember outcome of the disease, that they will ask you in orals. And when will you see the prognosis, when will you establish, when will you assess the prognosis is after making the diagnosis, before doing the treatment plan. So, it is between the diagnosis and treatment plan. The patient is having a generalized aggressive, that is your diagnosis. After doing a flap surgery with a graft, you will see the prognosis. Okay. So, if you are having a generalized aggressive, it's a diagnosis, whereas you are not giving a proper treatment plan, you are doing only with a scaling, root planing and just flap surgery, the prognosis is not going to be a good. So, it is after making the diagnosis, before making the treatment plan, the prognosis should be established. Okay. This is the outcome of the disease. These are all the different prognosis, prognostic factor, prognostic assessment, overall prognosis, individual tooth prognosis. This is the factors in determination of prognosis. Overall clinical factor, systemic and environmental factor, local factor, prosthetic and restorative. These things they can ask you in MCQ. What are the factors determining the prognosis? Overall clinical and systemic and environmental, local factor, prosthetic and restorative factor. Is it understood? This is pre-treatment, post-treatment. Risk factors. I told you when I am talking about smoking, I said it is one of the environmental risk factor. So, the risk assessment is defined by numerous components: risk factor, risk determinants, risk indicators, risk markers. See, these are all risk factors: environmental risk factor, systemic risk factor. Smoking is a environmental and diabetic is a systemic. Pathogenic bacteria and microbe again is environmental, that area, isn't it? Determinants and background is genetic factor, age, gender, these are all determinants. Indicators, risk, you should know the difference between risk factor, indicators, determinants and markers. So, the indicators are HIV, osteoporosis and then infrequent dental visits. Risk markers, the patient will have a previous history of periodontal disease and bleeding or probing will be a risk marker. You remember when I am saying about diagnosis, I said bleeding and probing is only a screening and it is a risk marker. So, by saying okay, the patient is having a bleeding and probing, one of the risk markers there, let us go ahead with another diagnosis, other investigations like that. Okay. So, risk marker, bleeding on probing, previous history of periodontal disease. Indicator is osteoporosis, infrequent dental visits and HIV and AIDS. Determinants are background characters, genetic, age, gender, socioeconomic stress. Usually they used to ask MCQs in this. They will ask determinants and risk factors and indicators and like that. And assessment. Individual risk for developing periodontal disease is obtained through careful evaluation. All these things, regular history. All these are regular history. And diagnostic aids. What are the different type of diagnostic aids they can ask you? Aids in microbiological identification and specific, and aids in immunological, and mainly ELISA will come under immunological diagnosis. Treatment plan I told you, first diagnose, then think about the prognosis, then you do the treatment plan. Phases of periodontal therapy 1, 2, 3, 4, non-surgical, surgical, restorative, maintenance. See, preliminary phases, phase 1, phase 2, phase 3, phase 4. I want you to understand two different things. This is phases of periodontal therapy. This is different from phases of maintenance therapy. Isn't it? Adla enna pannuvom? Phase 1 pannavana maintenance pannuvom. Then only we will go for a phase 2, phase 3, phase 4. Where is your preliminary phase? Phase 1, phase 2, phase 3, phase 4. See, emergency phase, non-surgical, maintenance, surgical and restorative. Till now I have given an introduction about this. Let us go with the discussion of the questions now. Okay. The implants are root form implants, endosseous implant, subperiosteal and transmandibular. What do you understand by this? This is actually according to the placement. Okay, well, selection of the site of the placement. That is, we call it as a root form implant. The type of periodontitis that rarely undergoes spontaneous remission. Rarely undergoes. This is generalized aggressive. Then which one will go easy? Which will go usually? Spontaneous remissions, chronic. So it rarely, why it rarely undergoes spontaneous remission? Because already there is a rapid bone loss. So you understand, so you won't forget it all. Alteration of this immunoglobulin found in diabetic mellitus, IgG. Why we are saying IgG? IgA will be more in saliva. Okay. IgG will be more in clavicular fluid. Here, the alteration of this immunoglobulin found in diabetic mellitus. In diabetic mellitus, what is the changes takes place in periodontium? Thickening of the vessels. Thickening of the vessels, blood supply is minimal. When there is a blood supply, what will happen? Widening of the periodontal ligament. There is a pocket formation. So, naturally, the IgG is altered. And Streptococcus mutant was often called as obligate periphyte. It is often called as obligate, whether aerobic, anaerobic, no, gram-negative, no. It is an obligate periphyte. Most frequently detected crystals in supragingival calculuses, hydroxyapatite and octacalcium phosphate. Why not brucite, magnesium? Brucite and magnesium will be subgingival. Usually magnesium and brucite where it will be? Vitcolite where it will be? Mandibular anteriors, most of them vitcolites will be there, and magnesium this will be the posteriors. And here anti-inflammatory cytokine is interleukin 10. See, remember, anti-inflammatory. Why it is called anti-inflammatory? When there is interleukin 1, TNF-alpha, interleukin, all three are called pro-inflammatory. So naturally interleukin 10 is anti-inflammatory. It is a family of zinc dependent enzyme, which one is MMP. Is a zinc. Why? Because chemokine is a cytokine. Cytokine is already written. PGE2 and MMP is a zinc dependent enzyme. Okay, this is, they are usually asking this. It is a zinc dependent enzyme. They are important in modifying and stimulating immune responses in the periodontium. Which one is bacterial fimbriae. Okay. They are important in modifying and stimulating immune responses in periodontium, bacterial fimbriae. Because usually cell wall, cell membrane, these are all will produce the toxins. Okay. LPS is endotoxins mainly released by means of P. gingivalis. Okay. It is a lymphocytic antigen MD2. Okay. It is a lymphocytic antigen that they are asking usually. Lymphocyte antigen. It is a lymphocyte antigen MD2. Neutrophils are the major sources of MMP8 and MMP9. Okay. Neutrophils it contains a primary granules. These granules will easily secrete MMP8 and MMP9, which is also zinc and calcium dependent enzyme. So MMP8 and MMP9 are mainly secreted by neutrophils. The origination and development of disease is called pathogenesis. So we mark it as C. Origination and development, that is why we call it as a pathogenesis. Typical fishy odor of the breath occurs due to increase of amines. Ketone will give fruity smell and volatile sulfur will give that rotten egg smell. Acetate also gives an offensive smell, it will come, but whereas fishy odor will come mainly in increase of amines, and usually this fishy smell will come for a kidney failure patients. Okay, kidney failure patients, uremic patients, you will have a amine thing, so there will be a fishy odor. Bartonian line is a sign of lead intoxication. This line usually be greyish black in color in the marginal gingiva. Okay, greyish black in the marginal gingiva. That is mainly because of the lead intoxication. We call it as a Bartonian line. Bisphosphonates acts by inhibiting osteoclastic activity. See, usually nowadays they are doing a research work on periodontal flap surgery with bisphosphonate because it inhibits the alveolar bone resorption. And step ladder alignment of trabeculae of the interdental septa occurs in sickle cell anemia. This usually they are asking in your entrance. Step ladder alignment of trabeculae of the interdental septa. Usually we are seeing only the lamina dura. We are giving importance for the interdental septa when we are seeing the IOPA. Okay. So usually the patient have a step ladder alignment of trabecula in the interdental septa. That is mainly due to sickle cell anemia. Exaggerated inflammatory response of local factors in pregnancy may be due to destruction of gingival mast cells by the increased sex hormone. Usually, in pregnancy, presence of P intermedia. No. P intermedia is a microorganism which is abundant in pregnancy. Understood? Yes. Why? Because it is more in pregnancy. Because this P intermedia will take a steroid as a growth factor. Usually any pregnancy gingivitis, the inflammatory response is mainly because of exaggerated tissue response. Here mainly because of destruction of mast cells due to increased sex hormone. You are able to understand? Should I repeat it? Lokesh? You want me to repeat it? I will repeat it. Usually I will tell you, in pregnancy gingivitis, you remember? I hear exaggerated inflammatory response of local factors. Usually நம்ம pregnancy gingivitis or puberty gingivitis, why there is a gingivitis கேட்கும் நம்ம என்ன பதில் சொல்லுவோம்? Exaggerated inflammatory response. And the exaggerated inflammatory response ஏன் வருது? Because of the sex hormones, there will be a destruction of the mast cells. Okay. At the same time, in case they are asking, the microorganism predominant in pregnancy gingivitis, then you can say P intermedia. Why the P intermedia? Because it uses steroid as a growth factor. Now we have understood, right? Then subgingival temperature in smoker is lowered. This microorganism is increased during pregnancy, P intermedia. Then myeloperoxidase is a bactericidal for AA. Repeatedly they are asking in entrance. Myeloperoxidase. People are writing C. rectus. No, C. rectus and Peptoseptococcus micros all will be in periodontal abscess, not in. Myeloperoxidase is a bactericidal for AA. Stress increases the production of cortisol. Okay. Because estrogen, progesterone are sex hormones, it is not working. And cortisol is a hormone which will be more in when there is a stress. And TIMP inhibits the activity of collagenase, tissue inhibitor of metallic proteinases. Okay. TIMP inhibits the activity of collagenase. MMP के opposite TIMP. Usually MMP சொல்றோம் இல்லையா, metalloproteinases. It's a tissue inhibitor of metalloproteinases. For example, tetracycline also acts on tissue inhibitor of metalloproteinases. Okay. So tissue inhibitor of metalloproteinases inhibits the activity of collagenase. Because this alkaline phosphatase, beta glucuronidase, these are the enzymes which is present in the saliva. Okay. So this collagenase is a TIMP, tissue inhibitor of metallic proteinases, metalloproteinases, inhibits the activity of collagenases. Metalloproteinases, TIMP. Okay. Organic matrix of the cementum is composed of type 1 and type 3 collagen. The gingiva is mainly made up of type 1 collagen. Periodontal ligament is mainly made up of type 1 collagen. So cementum, type 1 and type 3. And this fiber may be considered as belonging to gingiva. I told you, transseptal. The periodontal fiber which prevents the extrusion of the tooth is alveolar crest fiber. Okay. The periodontal fiber which prevents the extrusion of the tooth is alveolar crest fiber. The transseptal fiber enna sonnina, it is for both gingiva and periodontium. Oblique fiber enna sonnina, more amount in oblique. So in periodontal ligament, collagen turnover is regulated by what? Fibroblast. Why fibroblast regulates the collagen turnover in periodontal ligament? It's a principal cell. More amount in the oblique down. Principal cell of the fibroblast in periodontal ligament is fibroblast. That is the one which regulates the collagen turnover. Load bearing capacity of the implant is evaluated by periodontal index, Dunning and Leach index, periodontal disease index and bone appositional index. It is bone appositional index. Bone appositional index, because periodontal disease index and periodontal index, they are going to give a value about the periodontal things. Whereas load bearing capacity of the implant is by means of bone appositional index. And osteocrest, otherwise GORE, is a biodegradable membrane. Gore-Tex, Gore-Tex membrane. This is nothing but a osteocrest. You are able to understand? The BMP that shows strongest bone producing activity is BMP2, bone morphogenic protein. It is a direct graft which will initiate the bone formation. The bone which will be formed more is by means of bone morphogenic protein 2. The most common malignant tumor of the gingiva is squamous cell carcinoma. Because why it is most common than fibroma, lipoma and fibrocephalus? Yes, epithelium, isn't it? The common pattern of bone loss in periodontal is horizontal. Three-wall defects are more commonly seen in mesial surface of the upper and lower molars. Please, all these questions I have seen the book, I have not seen that book. This will be helpful, the question number 32. It is not given in your interesting also. It is on the mesial surface, not on the distal or buccal or lingual. It is mainly on the mesial surface of the upper and lower molars. The most common root resected in the maxillary first molar is distobuccal. We don't remove the palatal root, isn't it? Why? It is the largest one, strong one. If you remove that, there won't be any stability at all, isn't it? Usually we will remove the distobuccal root. A furcation in maxillary first premolar indicates poor prognosis. Usually premolar prognosis irukadu. Adile furcation premolar, there will be a poor prognosis. The most common causative microorganisms in periodontal abscess is Peptostreptococcus micros. Don't write Capnocytophaga, Staphylococcus gingivalis. Is mainly Peptostreptococcus micros. Perio test is used to detect tooth mobility. Tooth mobility can be measured by anything else other than perio test? Yes, mobilometer, periodontometer, perio test. Okay. Strawberry gums are seen in vaginous granulomatosis. And supine hypertensive syndrome occurs due to pressure in the inferior vena cava. Supine hypertensive syndrome occurs due to pressure in the inferior vena cava. If you are not understanding, stop me pa. Repeat pannuma pa edavudhu. Non-oral causes of halitosis is identified. I already told you, gas chromatography. Microdent is commercial PCR method. Usually they are asking microdent. Usually microdent is instrument chair side perio scan. No, it is a commercial PCR method. Intrabony defects were given a score of 8 in. Intrabony defects were given a score of 8 in Russell's index, because Rafford index is a periodontal disease index. Okay. So, Russell's index, when you are giving 8, that means the mobility index will go 3. Okay. And eosinophilic granules are primary granules of neutrophil. I think I am telling about this when I am taking the pathogenesis, isn't it? Neutrophils. Resistance developed by an individual as a result of antigenic stimulus is active immunity. Active. Immediate adicha odaniye ungalku varum. It is resistance developed by an individual as a result of antigenic. Edhu kadicha odaniye you will have a problem. If you are not having it, it is going to be an active immunity. Some antimicrobial dose of doxycycline is called as periostat. CHIP is chloroxylin. Pericline is minocycline. Elizal is metronidazole. Elizal is metronidazole. So, only this thing is periostat. Predominant cell type in GCF, PMN. Why there is a predominant cell type is PMN? Only then you will have a defense mechanism in the gingiva. An electronic transducer used to measure GCF is periotron. Because, see, periodontometer will see the mobility. RFA usually see the implant, stability of the implant can be measured by means of resonant frequency wave analysis, and halimeter for halitosis. Naturally, the existing one is periotron. Enamel pearl mimics subgingival calculus. So, enamel pearl mimics, people are writing as a peg-shaped or supragingival. No, it is wrong. You should write it is subgingival calculus. Cells also communicate one another in a biofilm via horizontal gene transfer. Okay. Cells also communicate with one another in the biofilm. So, in biofilm there are so many type of bacteria will be there, different type of cells will be there. Each cell will communicate each other by means of horizontal gene transfer. Cell to cell recognition and interaction of genetically distinct cell type is called as co-aggregation. Co-aggregation. For example, P. gingivalis and some other cell like aggregate and AA. Okay. Not P. gingivalis alone will be there, not AA alone will be there. Genetically distinct cells will get aggregated. And most common microorganism in oral flora is anaerobic streptococci. So, do not write gram positive, everybody is writing gram positive. Illa. The most common microorganism in the oral flora is anaerobic streptococci. Because P. intermedia வந்து pregnancy gingivitis la irukum, peri-implantitis la irukum, P. gingivalis chronic la irukum, positive cocci most of them will be with the abscess la irukum. So, the left one is anaerobic streptococci. When you are seeing this multiple choice question, you should not eliminate which is not correct also. Lateral foot impaction mainly occurs due to open gingival embrasure. See, overhanging margins of restoration, there is not going to be a lateral, isn't it? And improper tooth brushing is not going to be, and root caries also. The only left out is open gingival embrasure, because the foot impaction can be horizontal, vertical, lateral. Lateral modu open embrasures only. Gingival recession due to friction from soft tissue is known as ablation. Attrition you know, erosion you know, wear facets you know. The left out is ablation. Gingival recession due to friction form of soft tissue. Friction form of soft tissue vandale you should write about ablation. Atypical gingivitis is, I told you plasma cell gingivitis is an atypical gingivitis. Fever blisters, I told you it will be in herpes. Probable drug substitution in case of nifedipine drug induced. This is estradine. Okay? Tacrolimus you will put instead of cyclosporine. And this gabapentin and lomatrazine it will be instead of phenytoin. The left out is only estradine. It is only because of nifedipine. If they are getting enlargement, you can alter the drug by means of estradine. Okay? Bacterial endotoxins are detected in cemental wall of the periodontal pocket. Bacterial endotoxins. I told you when it is enters a gingival sulcus base intramuscular via the junction epithelium, it goes out mainly first in the cemental. Okay. So bacterial endotoxins, don't write in the lateral wall of the periodontal pocket, you will be having a granulation tissue. And the suprabony pocket, there is not going to be a toxin. When you do a SRP itself, it is going to become alright. Otherwise, you can do sometime gingivectomy or gingivoplasty when there is a suprabony pocket. Only when you are going to do a flap surgery when there is an infrabony pocket. So base of the pocket contains more of necrotic cementum and granulation tissue and endotoxins. So the first bacterial endotoxin is going to be detected mainly in cementum wall of the periodontal pocket. Don't get confused, okay? Lateral mainly all granulations will be there, and base all this PMN, necrotic tissue, necrotic cementum, all this will be there. Cementum side la mattunda mainly you will be having a bacterial endotoxins. Radiographic indicator of occlusal trauma is cemental tear. This is very important. Radiographic indicator of occlusal trauma is cemental tear. Saucer shaped way, arch shaped where you will get aggressive periodontitis. Saucer shaped where you will get periimplantitis. Bay like translucency where you will get cemental resorption. Bay like cemental resorption. Upper left out is what? Cemental tear. So when there is an occlusal trauma, I have already told you there is going to be a hypercementosis, all this. Whenever there is a functional demand arises, there is going to be an opposition, isn't it? So cemental tear is a radiographic indicator of occlusal trauma. So அதான் உங்களுக்கு இது மூணு எப்படி எக்ஸ்க்ளூட் பண்ணணும்னு தெரியணும். Bay like cemental resorption இருக்கும். Saucer shape periimplantitis ல இருக்கும். Arc shape aggressive ல இருக்கும். The left one is cemental tear. Okay. First you should know to exclude, then it will be easy for you to identify which is the one. And in trauma from occlusion, the marginal gingiva is unaffected. Index used to measure the severity of gingivitis in individual dentition. Papillary marginal attachment index, papillary marginal index, bleeding point index, sulcus. This is papillary marginal index. அங்க என்ன கொடுத்திருக்கான்? Indices used to measure severity in கேட்டிருக்கான். They were not asked about the gingival inflammation. Okay. Severity, whether it is severe or not. அதுக்கு papillary marginal index. Okay. Most keratinous part of the oral mucosa, hard palate. Oddland bodies are called, அங்க A விட்டுருக்குப்பா, அதை மாத்திக்க சொல்லுங்க. R க்கு A விட்டுருக்கு. No problem, no? Oddland bodies are called as keratinosomes. Oddland bodies are called as keratinosomes. Cells that are absent in junctional epithelium, Langerhans cells. Langerhans cell is otherwise known as clear cell, one of the clear cells. So, junctional epithelium la Langerhans cells won't be there. Gingival collagen that has a rapid turnover is type 1, isn't it? Another type 1 is more in periodontal ligament and gingiva, whereas type 1 and 3 is more in cementum. The mechanoreceptors in periodontal ligament are Meissner's corpuscles. Bay-like convexity, I told you, cemental resorption. The first sign of bone demineralization radiography is in the loss of, why there is a loss of laminar dura, we are saying the first sign, because it is the one which lines the socket wall. It lines the socket wall. When there is a periodontitis, the resorption going to start from the laminar dura. So this is a lamina dura. Loss of lamina dura means there is going to be a demineralization. It will be seen as a bone demineralization in the radiograph. Analytical studies include cohort study. Then you can ask why not longitudinal cross section. Longitudinal studies and cross sectional studies will come under descriptive studies. The rendume descriptive study. The left one is cohort study. So the analytical studies include cohort studies. The interradicular bone is cancellous, cortical, cribriform, lamina dura. Lamina dura kedayadu, cribriform kedayadu, cortical kedayadu. So the interradicular bone is cancellous. 70 minutes. Till now we have understood. Anything to be repeated? Eda innodara solli tharanuma?